Hello, my name is Meryl Davies, and I am lead antimicrobial pharmacist for primary and community care with Public Health Wales. And my session with you today is on the primary care antimicrobial guideline and its related audits. So in the session, we're going to cover why do we need antimicrobial prescribing guidance to begin with. Then we'll talk a little bit about the primary care antimicrobial guideline, how they're written, what's included in the guideline, and how we keep them up to date. And then we'll do the same for the antimicrobial audits. So why do we need antimicrobial guidance to begin with? Well, the problem we have on both an individual and a population basis is antibiotic resistance. And antibiotic resistance has been headline news for quite a while now, and especially since Dame Sally Davies, who was the then Chief Medical Officer back in 2013, stated that antibiotic resistance is as big a risk as terrorism to population health. And antimicrobial resistance has stayed in the headlines since then and has even made it to the tabloids, with the Daily Mail last year saying that global deaths from antibiotic-resistant superbugs have surged sevenfold in just half a decade to more than 5 million, experts suggests. So why are we concerned about antimicrobial resistance? So the British Medical Journal back in 2008 stated that without effective treatment and prevention of bacterial infections, we risk rolling back important achievements of modern medicine, such as major surgery, organ transplantation, and cancer chemotherapy. So the concern we have is that these procedures, which we count as routine procedures in this day and age, are very much reliant on effective antibacterial therapy. And if we don't have effective therapy to treat infections in these individuals, then these procedures will become far more risky in the future. So what can we do about antimicrobial resistance? So one of our tools is antimicrobial stewardship. And personally, I prefer the more practical or clinically based definitions of antimicrobial stewardship. So the British Journal of General Practice states that prudent prescribing is not to prescribe as few antibiotics as possible, but to identify that small group of patients who really need antibiotic treatment, and then explain, reassure, and educate the large group of patients who don't. Or as the CDC says, it's the right antibiotic for the right patient at the right time, with the right dose and the right route, causing the least harm to the patient and, importantly, to future patients. So this is where the primary care antimicrobial guideline comes in, as it promotes prudent use of antimicrobials. So how are they developed? Well, they're written and developed by the All Wales Antibiotic Guideline Group, which has a diverse membership, including consultant microbiologists, infectious disease consultants, antimicrobial pharmacists, and clinicians. And they are empirical guidance. They're indication specific, including dosing information and duration of treatment. So these are the guidelines that act as the basis for your local health board antimicrobial guidelines, which you can find on your antimicrobial guideline app. They're very much written based on available data. So we look at which pathogens are usually associated with an infection, and then which antibiotics are likely to be effective against those pathogens. We also look at our local resistance data. So, for example, we changed our empirical guidance for the management of lower UTIs in those over 65. So we no longer recommend trimethoprim as a first-line agent unless we've got a sensitivity result, because we know that trimethoprim resistance increases with age. We also look at the evidence base. So we look at recognised published guidance, such as NICE, UKHSA, BTS and BASH, and other hosts of guidance when we write our local guidance here in Wales. We also think about the antibiotic site of action, what sort of tissue penetration we need. We also consider the adverse effect of the antibiotic. An example would be the MHRA has released several warnings on the adverse effects of quinolones, and because of that, we limit the use of quinolones in the guidance to those indications where we have very little option for treatment. We also think about the severity of the infection. So if an infection is likely to be self-limiting or very much likely to be viral, then we would advocate a no antibiotic strategy. But then there are certain infections where there can be far more severe consequences to the patient. And then we think about which option should we be using for first-line agent in those sort of infections. We also consider the antibiotic spectrum of activity and favour narrow spectrum agents over broad spectrum agents where possible, because we know that broad spectrum agents are far more associated with the acquisition of antimicrobial resistant organisms and also the development of healthcare associated infections. So we limit the use of broad spectrum antibiotics within the guideline. So when you look at the guidelines, we're taking the example here of acute cough bronchitis. You will see a table under the headings of infection, formulary choice, adult dose unless otherwise specified, and the duration of treatment. So let's look at each section a little bit more detail. So taking the example of acute cough, it lists the indication and then it links to all the relevant guidance. So in this example, the NICE EKS and the NICE guideline. Again, we list advice regarding dosing in children. So as mentioned earlier, it's adult dosing unless otherwise specified, but we do link to the BNF for children. Where necessary, we will give advice on use in renal and hepatic impairment. For example, we recommend not using nitrofurantoin under a certain threshold of EGFR. We also provide indication-specific advice and warnings. So in this example, for lower respiratory tract infections, we note that low-dose penicillins are more likely to select out resistance, so to discourage the use of low-dose amoxicillin, and to not use quinolones first line due to poor pneumococcal activity. So this is an example where we're thinking about the likely organisms involved in the infection, and quinolones do not have good activity against those likely organisms. We also provide advice on when and when not to prescribe. So taking the example here of acute cough bronchitis, because the vast majority of these infections are viral in nature and we should not be prescribing antibiotics to treat them. First line is self-care with safety netting advice. Second line then is to consider a backup or delayed antibiotic prescribing strategy with safety netting advice. And that's because we know that backup or delayed prescribing strategies is a useful antimicrobial stewardship tool to promote prudent prescribing of antimicrobials. But we also list then those groups of patients or cohort of patients where we do consider immediate antibiotic prescribing. So in this case, it's our older population with certain risk factors where we should be considering immediate antibiotics. And that's because the risk of developing a more severe infection is more likely in this cohort of patients. We also give advice on relevant diagnostic tests and algorithms. So in this example, we advise considering the use of CRP testing if available, and then dependent on the result of the CRP, whether an antibiotic should be prescribed or not. Another example would be using the Centaur or fever pain score to assess whether a patient should be prescribed an antibiotic for a sore throat or not. So where we don't advise using an antibiotic, we do link to certain resources which will help with the safety netting of those patients. So there are several target leaflets available bilingually on the target website for different indications, which has excellent safety netting and self-care advice for patients. We give the antibiotic choice. We provide antibiotic choice in penicillin allergy or pregnancy where necessary, and also list antibiotic choice where resistance may be an issue. So as mentioned earlier, in the over 65s with a lower UTI, we no longer recommend trimethoprim first line unless we've got a sensitivity result. And because of that, give other options such as pivmecillinum and fosfomycin. And then for each antibiotic, we list the dose, the frequency, and the duration. So the guidance was first published in March 2022. And this then is the page that you see at the back of the guideline showing all the updates that have happened since that publication date in March 2022. So these updates are completed when we learn about new guidance or changes in advice, just to try and keep the guideline up to date and live. So if you have downloaded a PDF version of the guideline, please check back online just to make sure that you've got the most up-to-date version. So then moving on to the antimicrobial audits. There are several different types of audits. The first type are indication-specific audits, and these are very much targeted towards those infections that tend to be more viral in nature, or where you can use a backup or a delayed prescribing strategy. So the examples here are sore throat, rhinosinusitis, acute otitis media, and acute cough. And then we've also got the addition of the lower UTI in patients over 65 years, which is to look at the implementation of the new guidance because of the resistance factors in this cohort of patients. So These indication-specific audits very much support the NPI on total antimicrobial usage. And then we've got the 4C audits, which support the NPI on reduction of 4C antimicrobial usage. So looking at fluoroquinolone, cephalosporin, comoxiclav, and clindamycin prescribing. We also have another audit which looks at reviewing patients on long-term antibiotics. And this is to make sure that those patients on long-term antibiotics still need to be on those antibiotics, that they're still sensitive as well, so would be useful in that infection, and that any relevant monitoring has been completed. And the audit here is two-pronged in nature. It's one to try and reduce antimicrobial resistance, because if somebody's on an antibiotic and they don't need to be, then all we're doing is driving resistance, and also from a safety perspective. So we know that with certain long-term antibiotics, there are certain monitoring parameters that should be completed. For example, the MHRA recently have reiterated their warnings from the perspective of adverse effects of nitrofurantoin, whether they be used short-term or long-term. So when you look at the audit pack, you'll be provided with a background to the audit and also the relevant guidelines for that audit, and then a method of data collection listing what codes you should be using and which time frame we should be using when developing your search. And then we also have data collection sheets to ease with data collection process. And these are available both in Word and PDF versions, and also in Excel versions. So depending on which version you prefer to use, they're there for you to utilize. And what we would advocate is completing a baseline audit to begin with, looking at what you're doing well and where you could be improving, and then developing an action plan on how you can improve, and then re-audit then in a few months' time to see whether those actions have resulted in an improvement in your prescribing. And as for the primary care antimicrobial guideline, as the guidelines are updated, we update the audit as well. So thank you very much for listening. I hope you join me in the fight against antimicrobial resistance and keep our antibiotics working by using these excellent resources, the Primary Care Antimicrobial Guideline and the KEP National Audit, which focuses on antibiotic prescribing. Thank you very much.